Hello friends, now we are going to discuss peritoneum. In peritoneum, first of all, we are going to discuss the peritonitis. So see, what are the types of peritonitis? So in peritonitis, what are the types? Okay, so first, there is spontaneous bacterial peritonitis. It is also known as SBP in short. So spontaneous bacterial peritonitis. Second is secondary bacterial peritonitis, which is secondary to perforation, visceral perforation. So second is secondary bacterial peritonitis, and third is peritonitis in CAPD. What is CAPD? CAPD means chronic ambulatory peritoneal dialysis. Okay, so third is peritonitis in CAPD. Peritonitis is very important topic. It is asked mainly in surgery, but sometimes it is asked in medicine also. Okay, so one by one we are going to discuss. First we are going to discuss this spontaneous bacterial peritonitis, which is also known as SBP in short. Now see, what is the problem here? In spontaneous bacterial peritonitis, what is the problem? Spontaneously there was infection of ascitic fluid. So what happens here? Spontaneously there is infection of ascitic fluid. It means, what is the prerequisite for this spontaneous bacterial peritonitis? Ascites. And you must be knowing what is the most common cause of ascites in adults? Cirrhosis or chronic liver disease. And what is the most common cause of ascites in children? It's the nephrotic syndrome. Okay, so see, in spontaneous bacterial peritonitis there is spontaneous infection of ascitic fluid. Clear? So there is spontaneous infection of ascitic fluid. So what is the prerequisite here? The prerequisite is ascites. Okay, so what's the most common cause of ascites? Most common cause of ascites. Clear? If you're talking about cause in adults, it is cirrhosis or chronic liver disease, and in children it is nephrotic syndrome. So here it's cirrhosis or chronic liver disease, and in children it's the nephrotic syndrome. Clear? Now see how the organism reaches ascitic fluid. So actually speaking, in spontaneous bacterial peritonitis there is bacterial translocation. So you know that bacteria is in the gut. So from the gut, bacteria goes to mesenteric lymph node, and from mesenteric lymph node it reaches the ascitic fluid. So see the problem here. In SBP there is bacterial translocation. Clear? So there is bacterial translocation from gut to mesenteric lymph node. So from gut to mesenteric lymph node, and from mesenteric lymph node to ascitic fluid. Clear? So that's why it is spontaneous bacterial peritonitis. Now see, generally it's monomicrobial infection. It means a single organism is responsible for the infection. So what is the most common organism responsible for SBP in adults? It is E. coli followed by Klebsiella, and the most common organism in children, and that is group A streptococci. These two questions are asked in medicine also, surgery also, pediatrics also. Okay, so it's a monomicrobial infection. Monomicrobial means single organism is responsible. Okay, and what's the most common organism? And the most common organism responsible in adults and in children. So we discussed in adults. This is a question. In adults it is E. coli followed by Klebsiella, right? E. coli followed by Klebsiella, and in children it is group A streptococci. This question was asked many times. Group A streptococci. Simple. Now see, you have seen many patients of spontaneous bacterial peritonitis. Generally these patients are in which department? Adults are in medicine department, and kids are in the pediatrics. So what you have noticed, if a patient is having spontaneous bacterial peritonitis, this patient will be having pain all over abdomen, there will be tenderness all over abdomen, patient will be having tachycardia, and these patients will be having fever with chills and rigor. Whenever you are sending the blood investigations, what you're going to find, since there is infection and inflammation, so there is infection and inflammation, so there is raised ESR, and what else? Raised TLC count. Clear? So see the findings. First, the clinical features. There is pain and tenderness all over abdomen. Pain and tenderness. Clear? All over abdomen. Simultaneously, these patients have what? There is fever with chills and rigor. So there is fever with chills and rigor. What else? These patients have tachycardia on examination. Simple. Whenever we are going for investigations, see, investigations, first laboratory investigations. So what you're going to find, there is raised ESR and raised TLC, total leukocyte count. Okay. Now, in the patients who are having spontaneous bacterial peritonitis, we are going to aspirate the ascitic fluid, and this is known as paracentesis. And when we perform paracentesis, we are going to send this ascitic fluid for bacterial examination, means culture and sensitivity, and microscopic examination. Clear? So we perform paracentesis, and on paracentesis, what's the diagnostic criteria? This question was asked many times in NEET. Diagnostic criteria for SBP. So on paracentesis, there is monomicrobial growth. If you send it for culture, there is monomicrobial growth. So single R is responsible. And see, the neutrophils, you have to remember the number. What should be the number of neutrophils? More than 250 per mm cube. This is the diagnostic criteria, and this is the question which is asked. Clear? So diagnosis is done. How we are going to treat it? So since infection is there, we have to give antibiotics. Which one? Generally we prefer IV cefotoxim, and with IV cefotoxim we give albumin. Why we give albumin? You must be knowing that the patients of cirrhosis are having impaired synthesis of albumin, so they have hypoalbuminemia. And the patients of nephrotic syndrome, they have excretion of albumin in the urine, so they have albuminuria, leading to hypoalbuminemia, right? And because of this, there is more ascites. So to improve the signs and symptoms, we give albumin. So how we are going to treat it? Management. So we give IV cefotoxim, clear, plus albumin. So this is spontaneous bacterial peritonitis. Now see the secondary bacterial peritonitis. Secondary bacterial peritonitis. So here the term is self-explanatory. What? That it's a bacterial peritonitis secondary to something. So secondary to what? Secondary to visceral perforation. So this bacterial peritonitis is secondary to visceral perforation. Clear? Especially the small bowel or large bowel perforation. So in small bowel or large bowel, when the fecal matter is there, you must be knowing there are two organisms which are present. One is aerobe, that is E. coli, which is present in the fecal matter, and the second is anaerobe. Which one? Bacteroides fragilis. So here it's polymicrobial. See, so it's because of visceral perforation. And what are the organisms responsible? Organisms, since it's polymicrobial. So the questions are asked that what is the most common aerobe responsible and most common anaerobe responsible or isolated. So the organisms E. coli and bacteroids. Clear? So it's E. coli and bacteroids. E. coli is an aerobe, bacteroids is an anaerobe. You have seen many patients of perforation peritonitis in surgery emergency. So when these patients are brought to emergency, first we resuscitate the patient. Clear? We give IV fluid, we insert Ryle's tube, Foley's catheter. After resuscitation, we have to confirm the diagnosis, so we send the patient for X-ray. And when there is pneumoperitoneum, means gas under diaphragm, then we take the patient for surgery. And what we perform? We perform exploratory laparotomy, we perform peritoneal lavage, we repair the perforation or perform the stoma, and we put the drain. Clear? So how we are going to manage? Management is the exploratory laparotomy plus peritoneal lavage plus repair of perforation, or if massive contamination is there, if there is massive contamination, we go for stoma formation. So repair of perforation or we go for stoma. Okay, so stoma is created. This is how we manage secondary bacterial peritonitis. Now the third type is peritonitis in CAPD. What happens here? See, there is peritonitis in the patients of CAPD. What is the full form of CAPD? Chronic ambulatory peritoneal dialysis. There are many patients who are not able to afford the transplantation, renal transplantation or hemodialysis. The patients of CRF, chronic renal failure, who is not able to afford hemodialysis or renal transplantation. So what we do in such patients, see, this is the peritoneal cavity of the patient and this is the bowel. Okay, inside the peritoneal cavity, we are going to insert the catheter. So what's the name of this catheter? This is peritoneal catheter. And we give the dialysis fluid to the patient. Okay, we explain how to use it. So how patient is going to use that? This is the dialysis fluid and this dialyzing fluid is attached to the catheter. Patient is in the lying down position. So whatever the fluid is there, this fluid goes into the peritoneal cavity. Simple. You know that peritoneum is a semi-permeable membrane. So via this semi-permeable membrane, there is exchange of toxins. Clear? So what happens? Whenever the fluid is inside the peritoneal cavity, there is exchange of toxins. And after 4 to 6 hours, patient is going to detach this peritoneal catheter. And whatever the fluid is there inside the peritoneal cavity, this fluid is drained out. This is done on daily basis. Clear? And the fluid is there for 4 to 6 hours in the peritoneal cavity. So since it is done in ambulatory patient on daily basis, so what's the name? It's known as chronic ambulatory peritoneal dialysis. Now the problem, you must be knowing that there is one organism which is going to colonize implants and catheter. What is the another hint about this particular organism? It is going to produce the slime. So the organism is going to produce the slime and it is going to colonize the catheter or implant. So this organism is Staph epidermidis. So it is going to colonize the implant or this catheter, and because of this it is responsible for peritonitis in CAPD. So question which is asked, that what is the most common organism responsible for peritonitis in CAPD? It is the Staph epidermidis. Okay, so first important point, that most common organism responsible, and it's the Staph epidermidis. Clear? Why? Because this organism produces slime and it is going to colonize implants and catheter. Now it's very easy to treat it. How? Via the catheter only. What you do? You instill first generation cephalosporin. So via catheter only, we go for intraperitoneal instillation of first generation cephalosporin, and most of the patients improve. There is a second situation. Suppose patient is having recurrent attacks of peritonitis. It means the catheter is still having the organism, and in that case what we do? Change the catheter. So how we are going to manage? Management. So we go for intraperitoneal instillation of first generation cephalosporin. First generation cephalosporin. Clear? And if patients are having recurrent attacks. So in cases of recurrent attacks, what we have to go for in those cases, change the catheter. So change the catheter. So this is how we manage peritonitis in CAPD. Now see, you have seen the patients of secondary bacterial peritonitis in whom we perform the laparotomy, and you have seen the patient in the ward. If you have noticed that in the patient we are going to insert a drain and there is a single drain, you have noticed that that single drain has been inserted on the right side in hepato-Morrison pouch. And if there are two drains, you are going to notice that the second drain is inserted where? In the pelvis. So what is the logic? Why one drain is inserted into hepato-Morrison pouch if there is only one drain? And if two drains are inserted, one is inserted in the pelvis or pouch of Douglas. Okay, there is very simple logic. Now see these two images. Here you can see that patient is in the lying down position or patient is in the recumbent position. So what is the most dependent cavity when patient is in the lying down position or in the recumbent position? And you can see here it's the hepato-Morrison pouch, which is also known as right subhepatic space. This is the most dependent cavity. And if you see, if patient is in the upright posture, what is the most dependent cavity? And the most dependent cavity is recto-uterine pouch, that is also known as pouch of Douglas. It is also known as rectovesical pouch in males. So what's the name of this pouch? This is known as pouch of Douglas. Okay, so indirectly what? This is the pelvis. Clear? So this is what? This is the pelvis. Okay. So two questions. What is the most dependent cavity when patient is in the lying down position or in the recumbent position? And that is hepato-Morrison pouch, also known as right subhepatic space. So it's the hepato-Morrison pouch, also known as right subhepatic space. Clear? And what is the most dependent cavity when the patient is in upright posture? And that is pelvis or pouch of Douglas. Clear? Now see the application. So similarly, the question is asked that what is the most common site of intraperitoneal abscess if patient is in the recumbent position or in the lying down position? So it's the hepato-Morrison pouch. And what is the most common site of intraperitoneal abscess if the patient is ambulatory or patient is in the upright posture? And that's pelvis. So two important questions. Hepato-Morrison pouch, this is the most common site of intraperitoneal abscess if the patient is in the lying down position. Here you can see lying down position or recumbent position. Clear? Okay. And in upright posture, so if the patient is in upright posture or the patient is ambulatory patient, what's the most common site of intraperitoneal abscess? And the most common site of intraperitoneal abscess, and that's pelvis. Clear? So in detail we are going to discuss pelvic abscess, because overall if you want to see what's the most common site of intraperitoneal abscess, overall it's pelvis. Clear? So in detail we are going to discuss pelvic abscess. Pelvic abscess. Clear? So overall it's the most common site of intraperitoneal abscess. Now see the relation to understand the clinical features. So what happens in this pouch of Douglas? There is collection of pus. Can you see here? So there is pus collection. So if there is pus collection, so what will happen? Because of pus, we discussed that there is pain and tenderness. So this patient will be having pain in the lower abdomen. One, since pus collection is there, this patient will be having fever with chills and rigor. And third problem, can you see the relation of this pouch of Douglas with anterior wall of rectum? Right? So what is the problem? It is going to irritate the anterior wall of rectum, and because of that this patient will be having multiple episodes of loose stools with passage of mucus. Clear? So clinical features. These patients have pain in lower abdomen, So there is pain in lower abdomen. What else? These patients have fever with chills and rigor. Fever with chills and rigor. And third, very important, these patients have multiple episodes of loose stools. Multiple episodes of loose stools. And in the stool, patient is going to pass what? Mucus. So with passage of mucus. So there is passage of mucus. Clear? Now, whenever we are going to perform the examination, see, if I'm going to perform the digital rectal examination, I'm going to notice the bulge. So where is the bulge? Yes, you can notice the bulge on the anterior wall of rectum. Clear? So there is bulge over the anterior wall of rectum. So on digital rectal examination, you can see here that there is bulge on anterior wall of rectum. Simple. Now see, these patients are there in the ward. Whenever we are going to suspect the pelvic abscess, we are sending these patients first, because we suspect some collection, we send the patient for ultrasound. Clear? So what is the first investigation done in patients of pelvic abscess? Ultrasound. But what is the investigation of choice for diagnosis? It is CCT. Clear? So how we are going to make the diagnosis? Diagnosis. The first investigation is ultrasound. And what's the investigation of choice for diagnosis? And this is CCT. Clear? See, our resident is also going to accompany the patient to the radiology department. So when radiologist is performing ultrasound, our resident is going to ask the radiologist that, sir, how much collection is there? And what is the exact location? Can I aspirate it? Is there a clean window? So if there is clean window, means you can insert the needle. Generally what we do via percutaneous aspiration. Ultrasound guided or CT guided percutaneous aspiration. We are going to aspirate it. So what is the preferred treatment? Ultrasound or CT guided percutaneous aspiration. Sometimes the bowel loops are adhered, so you don't have a clean window. So if there is no clean window, what is the preferred route in females? Can you see here? You can see the posterior wall of vagina is in close contact with this pouch of Douglas. So what we do, we are going to drain it via posterior wall of vagina, and this is known as what? This is known as posterior colpotomy. Clear? In females. And in males, what we are going to do, we are going to drain it via anterior wall of rectum. Can you see here? So it's drained like this. So it is drained via anterior wall of rectum. So this is how we manage. So see the management. Preferred is ultrasound or CT guided percutaneous aspiration. This is preferred if clean window is there. Means if you are able to aspirate, there is no bowel in between. And if it's not possible, in females, we go for posterior colpotomy. So drainage is done via posterior colpotomy. Clear? And in males, rectal drainage via anterior wall of rectum. Via anterior wall. So this is how we manage the patients of pelvic abscess. Now we are going to discuss very important topic which was asked in INI CET and FMG exam of 2020. It's mesenteric cyst. Very important topic. Mesenteric cyst. Okay. So first question, where is the cyst? So in this case, the cyst is located in the mesentery. Generally, mesenteric cyst is more common in females, and in which particular age group? Yes, these females are in second decade, so generally age is approximately near 20 years. Clear? What are the types of mesenteric cyst? The most common type is chylolymphatic. And what is the second most common type? It is enterogenous. Okay, so see the types of mesenteric cyst. Most common type, it's chylolymphatic. Second most common type, it is enterogenous. Third is simple or mesothelial. And fourth, arising from urogenital remnant. So simple or mesothelial. Clear? Arising from urogenital remnant, okay, and dermoid. These are the types. So what are the questions? First, most common is chylolymphatic, and second most common is enterogenous. We are going to discuss these two cysts in detail. So see what are the differences. See the differences. So first is chylolymphatic, okay, and the second is enterogenous. It's very easy to understand. See, just break it. So if you break it, chylo means what kind of collection? This cyst is having chylous collection. And lymphatic, so where is the problem? Problem is there in the lymphatic. Yes, so there is congenital misplaced lymphatics. Where? In the mesentery of ileum. And in this, what is the problem? These lymphatics are having only afferent, no efferent. It means only afferent is there, so there is only incoming of lymph, there is no outgoing. So if there is no drainage or no outgoing, the lymph is going to collect in the mesentery, leading to formation of the cyst. So what's the problem? It's characterized by congenitally misplaced lymphatics. Congenitally misplaced lymphatics. Clear? So what is the problem? What is mesentery? Mesentery is the lymphovascular supply. Can you see? It's the lymphovascular supply of the bowel. So what is the problem here? Here you can see there is afferent lymphatics. Clear? And this is the efferent lymphatics. What is the problem? There is congenitally misplaced lymphatics with afferents only. So there is only afferents. There is no efferents. So if there are no efferents, what will happen? Because of afferent, the chyle is coming and this chyle starts collecting in the mesentery. And because of that, you will notice that slowly there is enlargement of this swelling. So what happens? There is formation of chylolymphatic cyst. If you see this diagram, this is chylolymphatic cyst. Here you can see that this cyst is having its independent vascular supply. Can you see? It is having independent vascular supply and there is no shared wall. And if there is no shared wall, what you can go for? You can easily go for enucleation. Now see grossly how this cyst looks like. So here you can see, can you see in relation to mesentery, this is the cyst. And can you see the chylous fluid collected inside? So important points related here. There is chylous fluid. It is having independent vascular supply. Independent vascular supply. Clear? And there is no shared wall. And since there is no shared wall, what's the treatment? In these patients, we go for enucleation. The treatment in chylolymphatic cyst is enucleation. Now see enterogenous, break it. Entero means small bowel, genus means origin. So it is directly or indirectly originating from small bowel. How? See, generally these patients have what? Duplication cyst. These patients have either diverticular or duplication cyst. What is the meaning? See, so this is the mesentery and these patients have diverticular or duplication cyst. Now over a period of time, can you see this is diverticula and it is walled off. So when diverticula is walled off, there are two separate lumens. This is duplication cyst. Now the problem, what is the lining of small intestine? The lining is columnar epithelium, and in small intestine, in this columnar epithelium, there is presence of what? Goblet cells. So columnar epithelium and there is presence of goblet cells, and these goblet cells are going to secrete mucin, and this mucin keeps on collecting inside the cyst. Which one? Duplication cyst. And slowly you will notice that there is enlargement in the size of cyst. So what's the problem? Here you can see that there is shared wall and shared vascular supply. And if there is shared wall and shared vascular supply, in that case, if you want to resect the cyst, you have to excise the accompanying bowel also. So here the treatment is resection and anastomosis. Can you see in this picture there is shared wall and shared vascular supply. Clear? So see the important points related to enterogenous cyst. It arises from either diverticular or duplication cyst. In relation to small intestine, what kind of content is there? Mucinous. So there is mucinous content. Clear? And if you see the cyst, can you see here? This wall is shared and simultaneously you can see there is shared vascular supply also. That's why in these cases we perform resection and anastomosis. So the problem here, there is shared wall and shared vascular supply. So since there is shared wall and shared vascular supply, how we are going to treat it? The treatment is resection and anastomosis. So the treatment, it's resection and anastomosis. Clear? Now see the questions related to anatomy and the questions related to signs and symptoms. Now see what is mesentery and what is the extent of mesentery. Mesentery is fan-shaped structure via which the bowel is hanged from posterior abdominal wall. The extent of mesentery, on the left side it starts from left side of L2 vertebra and it goes to right sacroiliac joint. So this is the line of attachment of mesentery. Now the problem, if you are going to notice a swelling in relation to mesentery, generally this swelling will be moving perpendicular to the attachment of mesentery or the swelling will be moving along the attachment of mesentery. So obviously the mobility of cyst will be perpendicular to the attachment of mesentery, and this was the question which was asked for the first time in INI-CET 2020. And what was the question in INI-CET 2020? First time this question was asked, Tilloch sign. Previously they were asking Tilloch's triad, but this time they asked Tilloch's sign. So what is this Tilloch sign? Yes, here the cyst moves perpendicular to the attachment of mesentery. Clear? Here the mesenteric cyst is moving perpendicular to the attachment of mesentery. This is Tilloch's sign. What is Tilloch's triad? You will notice what kind of swelling is there? Cystic. Okay, so there is soft fluctuant swelling in periumbilical region. If you perform the percussion around periumbilical region, you will notice that there is zone of hyperresonance. Why? Because cyst contains liquid, so cyst is dull. Around cyst there is hyperresonance and it is moving perpendicular to the attachment of mesentery. Okay, so this is the Tilloch's triad. Okay, so you got the difference between Tilloch sign and triad. Sign is only movement perpendicular to the attachment of mesentery. So what is triad? The components: soft fluctuant swelling in periumbilical region, zone of hyperresonance around the swelling, zone of hyperresonance around the swelling, and moving perpendicular to the attachment. Moving perpendicular to the attachment of mesentery. Attachment of mesentery. Clear? These are the frequently asked questions. Okay. Now if you're talking about signs and symptoms, see, this is the triad. In majority of cases, the patient is asymptomatic. What is the age of patient? 20 years. More common in females, and these patients have abdominal distension which is occurring over a long period of time. It's slow, so patient is having abdominal distension, but the patients are asymptomatic. What's the problem? These patients, young female, 20 years old female, unmarried, if the female is unmarried, she is not noticing the abdominal distension, but what the aunties of that society or colony is going to notice, that look, that unmarried female is having what? Abdominal distension. So we had 2-3 cases, clear, where the girl was completely innocent, there was nothing like this, right? So the problems, clinical features, most patients are asymptomatic and we discussed that it is seen in young females age 20. What is the symptom? These patients have abdominal distension. Clear? And that's why what is the first investigation done? It's the ultrasound. But what is investigation of choice for diagnosis? CCT. So how we are going to make the diagnosis? First investigation, it's the ultrasound, and the investigation of choice for diagnosis, and that is CCT. Clear? And we discussed how we are going to treat if patient is having chylolymphatic cyst. It's the enucleation. And if the patient is having enterogenous cyst, in that case resection and anastomosis. We discussed in which cases we are going to perform enucleation. So if you remember, hemangioma liver, leiomyoma esophagus, chylolymphatic cyst, and insulinoma involving head of pancreas. In these four conditions, hemangioma liver, leiomyoma esophagus, chylolymphatic cyst, and insulinoma involving head of pancreas. So in these four conditions we perform enucleation. Now see these pictures and tell me what is the diagnosis. First, what you see, can you see here? Here the mesentery is studded with what? Jelly-like substance. So what? Mucin. So you can see almost whole mesentery is studded with jelly-like substance, and this is mucin. And can you see, if you see, this is the peritoneal cavity, can you see there is jelly-like substance which is going to fill almost whole peritoneal cavity. So the name of this condition is pseudomyxoma peritonei. So what's the name? Name of this condition, it's known as pseudomyxoma peritonei. And what you are going to notice in these images, that there is mucinous ascites. There is collection of jelly-like substance in the peritoneal cavity, and this jelly-like substance is going to deposit over the peritoneum. Clear? So what is the cause of pseudomyxoma peritonei? What's the cause? It is caused by rupture of mucinous adenocarcinoma. And what is the most common site of primary? It is appendix followed by ovary. Clear? So pseudomyxoma peritonei, it is caused by rupture of mucinous adenocarcinoma. So what? This malignancy is producing excessive amount of mucin. Right? And see, what's the most common primary? It's a famous question. And the most common primary, it's appendix followed by ovary. How to remember? Appendix is present both in males and females. That's why the most common site is appendix. Now see, if we see, generally it is seen in both males and females, and in which decade? 4th to 5th decade. So it's seen in 4th to 5th decade, right? Now see, in this patient, the jelly-like substance is collected. Initially, these patients are asymptomatic, right? But what is the problem? The amino acids are generally completely used in the production of this jelly or mucin. So what happens? You will notice that there is global deterioration of health. And since there is collection of this jelly-like substance in the abdominal cavity, so you will notice that there is abdominal distension. Now imagine if the patient is in the lying down position. And see, this is the bowel. In this patient, there is collection of this jelly-like substance or mucin. So initially patient is asymptomatic, but when this collection becomes significant and patient is going to eat something, after that patient is going to lie down, this substance is going to compress the bowel. So suppose this is the bowel, it is going to compress it. So generally what happens? There is partial obstruction or complete obstruction. Partial. So the patient is going to complain that, sir, after meals I'm having colicky pain, but patient is going to tell you that I pass feces and flatus. One problem, over a period of time, since there is collection of jelly-like substance, so there is abdominal distension, and because of this abdominal distension there is increased intra-abdominal pressure, and when there is increased intra-abdominal pressure, because of that the patient is going to develop multiple hernia. So someday this patient might come to your OPD saying that, sir, I developed 2 to 3 hernias. Clear? So these are the presentations. See the clinical features. Clinical features. Initially, patients are asymptomatic. Clear? There is abdominal distension. There is colicky pain after meals, colicky pain especially after meals. And because of this abdominal distension, there is increased intra-abdominal pressure, and because of that, these patients might develop multiple hernias. And over the period of time, what's the problem? Over a period of time, these patients have global deterioration of health. Why? Because amino acids are used up in production of jelly. So global deterioration of health. Okay, you have seen the patients of ascites in medicine and surgery also. And whenever you are going to perform the examination, there is shifting dullness. What shifting dullness is there? But for shifting dullness, there should be fluid inside the abdomen. Here, there is ascites, but it is mucinous. It means semi-solid substance is collected. So how you can differentiate this ascites from normal ascites? That in this case, there is no shifting dullness. So what else? On examination, you are going to find ascites. Ascites without shifting dullness. So there is ascites without shifting dullness. Clear? How we are going to make the diagnosis? Investigation of choice for diagnosis of pseudomyxoma peritonei, it's the CCT. So see how we are going to make the diagnosis. Investigation of choice for diagnosis, and this is the CCT. Diagnosis is done. Now see the treatment principle. What's the problem? Here, there is ruptured mucinous adenocarcinoma. Mucin is containing tumor cells, and these tumor cells are deposited on the surface of mesentery or peritoneum. In this case, which principle is followed? We have to go for cytoreduction. What is the meaning of cytoreduction? Means remove the maximum amount of tumor. But it's not possible to remove all tumor cells. That's why after performing cytoreduction, we go for HIPEC. What is HIPEC? It's the hyperthermic intraperitoneal chemotherapy. Clear? And how we perform the cytoreduction? Since omentum is studded with these jelly or mucin containing tumor cells, we have to perform the omentectomy. We excise the greater omentum. Omentectomy is done. Now if you see the peritoneum is also studded with jelly-like substance. So what you do? You strip it. So this stripping of peritoneum is known as peritonectomy. So you perform omentectomy, you perform peritonectomy. Most common primary is in appendix. So for appendicular malignancies, what's the treatment of choice? It's the right hemicolectomy. So we perform right hemicolectomy. But if a patient is female, apart from all these procedures, you also perform bilateral salpingo-oophorectomy because ovary might be the site. Okay. So how we manage treatment? You have to remember the principle. Treatment principle is the cytoreduction plus HIPEC. What is the full form of HIPEC? It's the hyperthermic intraperitoneal chemotherapy. There is another indication of HIPEC. You tell me. Another indication, similar indication. So whenever there is peritoneal carcinomatosis, when the metastasis is there to the peritoneum, in that case also we use HIPEC. Okay. Now see, what are the components of this cytoreduction? Okay. So we perform omentectomy. We perform stripping of peritoneum, and that's known as peritonectomy. And since the primary is most commonly in appendix, we perform right hemicolectomy. And if a female patient is there, apart from all this, what else is done? In females, we perform bilateral salpingo-oophorectomy. Clear? So in females, we perform bilateral salpingo-oophorectomy in addition to omentectomy, peritonectomy and right hemicolectomy. Now we are going to discuss retroperitoneal fibrosis. Okay, retroperitoneal fibrosis. Clear? So what is happening in this retroperitoneal fibrosis? Yes, there is fibrotic proliferation into the retroperitoneum. So what happens? There is fibrotic proliferation in the retroperitoneum. First, see what are the boundaries of retroperitoneum. So if you see the boundaries, superiorly there is dome of diaphragm. Superiorly, inferiorly there is levator ani. Posteriorly there is psoas muscle posteriorly, and since it is retroperitoneum, so anteriorly there is peritoneum. So you can see superiorly dome of diaphragm, inferiorly levator ani, posteriorly psoas muscle, anteriorly peritoneum. So this is dome of diaphragm, this is psoas muscle, this is levator ani. Another important thing, what are the retroperitoneal structures? So if you see, there is C loop of duodenum and pancreas, ascending colon and descending colon. Which part? Only posterior part, because the anterior part is intraperitoneal. So it's the posterior part of ascending and descending colon. Okay. After that, kidney, adrenal, ureter. Kidney, adrenal, ureter. After that, this is inferior vena cava, and what else? This is aorta. Clear? These are the retroperitoneal structure. What happens in retroperitoneal fibrosis? You can see here there is fibrotic proliferation, which starts in retroperitoneum. Where exactly? From the aortic bifurcation. Can you see? So, and it is going to move cranially upwards. Clear? So here you can see there is fibrotic proliferation in retroperitoneum, especially in the paravertebral region, and it moves cranially upwards. So what are the three tubular structures which are involved here? Most commonly involved is the weakest structure, and that is ureter, followed by IVC, followed by aorta. Clear? So see, the fibrotic proliferation, it starts from aortic bifurcation. Clear? And it moves cranially upwards. Simple. Here you can see what are the three structures which are most commonly involved. Out of these three, the most commonly involved structure, that's ureter, followed by inferior vena cava, followed by aorta. Clear? So it's ureter, followed by inferior vena cava, followed by aorta. Now what are the types of retroperitoneal fibrosis? It is of two types. One is primary, also known as idiopathic retroperitoneal fibrosis. Idiopathic means the cause is not known. And this idiopathic retroperitoneal fibrosis is also known as Ormond's disease. Frequently asked one-liner question. So see the types of retroperitoneal fibrosis. First is idiopathic or primary retroperitoneal fibrosis. This is the question, known as Ormond's disease. Clear? And the second is secondary. This is the secondary retroperitoneal fibrosis. Clear? So it is secondary to something. So what are the causes of secondary retroperitoneal fibrosis? So see the causes. It can be seen secondary to chronic inflammation. There are many drugs which can lead to secondary retroperitoneal fibrosis. Malignancies, autoimmune disorders, and radiation exposure. These are the causes. Clear? Now what are the questions which are asked? Okay, so what are the states of chronic inflammation which is going to increase the risk? First, chronic pancreatitis. See, that state should be in relation to retroperitoneum, and you know pancreas is located in retroperitoneum. So what is the chronic pancreatitis? Okay, second, actinomycosis. Third, tuberculosis, and fourth, histoplasmosis. Clear? So how to remember? The mnemonic is cath. Can you see? Cath. So you will not forget. The chronic inflammation mnemonic is cath. Drugs causing retroperitoneal fibrosis. This is also important, asked in medicine as well as in pharma. And the most important drug is methisergide. See the list. So the most important drug is methisergide. This is most important. Other drugs are amphetamines, hydralazine, entacapone, beta blockers, bromocriptine, phenacetin. And how to remember? The mnemonic is MAHE BP. Initially there was a separate exam for Manipal that was known as MAHE. So MAHE BP. What are the malignancies which are going to increase the risk? So it's the non-Hodgkin's lymphoma, carcinoma stomach, and carcinoid tumor. In these malignancies also, especially carcinoid tumor, there is extensive fibrosis. So these are the causes of secondary retroperitoneal fibrosis. Now see this condition again. This is kidney, this is the ureter, this is the bladder. We discussed that most commonly involved structure is ureter. Okay, so whenever this fibrosis starts from paravertebral region, aortic bifurcation, it is moving cranially upwards. Yes, there is extrinsic compression of ureter, and whenever there is extrinsic compression, what is the problem? These patients are having signs and symptoms of obstructive uropathy. But before that, when this fibrotic proliferation starts in retroperitoneum, these patients are having non-specific dull aching pain, and this is the most common symptom. Clear? So see the clinical features. The question which is asked frequently, what's the most common symptom? Clear? And these patients have non-specific dull aching back pain. So there is non-specific dull aching back pain. In exam, only back pain is mentioned, so you have to mark that. Specific signs and symptoms, and the specific signs and symptoms are signs and symptoms of obstructive uropathy. Clear? So these patients have signs and symptoms of obstructive uropathy. So these patients might have increased frequency. There is dysuria. And because of obstruction, there is hydronephrosis. Sometimes this hydronephrosis is infected, and then patient is going to develop fever. So fever because of infected hydronephrosis. So these are the manifestations. Since the pathology is located in the retroperitoneum, you must be knowing what is the investigation of choice for diagnosis? CCT. So how we are going to make the diagnosis? Investigation of choice for diagnosis, and that is CCT. Okay, after that one-liner questions are asked. See, whenever there is inflammation in this region, can you see? If there is inflammation in this region, because of this inflammation, what happens? There is fibrosis. And if there is fibrosis, because of fibrosis, there is contraction. And if there is contraction, what happens? There is medial deviation of ureter, or there is lateral deviation of ureter. So in these cases, because of fibrosis, there is contraction and there is medial deviation of ureter. This is known as medial pulling, also known as pipe stem ureter. And on which investigation you are going to find this? On IVP. So if we go for IVP, there is medial deviation or medial pulling, and this medial deviation of ureter is also known as pipe stem ureter. It's also known as pipe stem ureter. Simple. Sometimes the patients are having retroperitoneal sarcoma. And how on the basis of IVP you can differentiate? Imagine this is the kidney, this is the ureter, clear? And this is the bladder. Simple. Here there is malignancy, retroperitoneal sarcoma. So whenever there is increase in the size of this retroperitoneal sarcoma, what will happen? The ureters are stretched. So there is lateral deviation. So if the malignancy, can you see there is enlargement of the size? So what will happen? Can you see the ureters are stretched like this? So what happens? There is lateral deviation. So in retroperitoneal fibrosis, there is medial deviation, but in retroperitoneal sarcoma, there is lateral deviation of ureter. Clear? So this is how you can differentiate retroperitoneal fibrosis from retroperitoneal sarcoma. Now see how we treat. So the main problem here is because of retroperitoneal fibrosis leading to what? Ureteric obstruction, and second, ongoing inflammation. Two problems. So first, if the patient is having primary retroperitoneal fibrosis, since there is extrinsic compression, the ureter lumen is patent. So what we do, we are going to insert DJ stent. So if the patient is having primary retroperitoneal fibrosis, first you have to perform the DJ stenting bilaterally. So lumen, now it's clear. Okay, now there is no obstruction. Second, since there is ongoing inflammation, so you have to control the inflammation with the help of immunosuppressive agents. So management, I insert DJ stent bilaterally. So the management, first, primary retroperitoneal fibrosis. So in primary retroperitoneal fibrosis, we go for ureteric stenting and we give immunosuppressive drugs or agents. And what are those immunosuppressive agents which are used? This is asked in medicine, it is asked in surgery, it is remembered by the mnemonic TAPS. TAPS, so it's tamoxifen. A, you must be knowing azathioprine. P, that's penicillamine, it's the penicillamine, and S, it's steroids. Clear? Tamoxifen, azathioprine, penicillamine, steroids. So these are the drugs which are used in primary retroperitoneal fibrosis. In secondary retroperitoneal fibrosis, what we do? We perform laparotomy. And around the ureter, since there is fibrosis, extensive fibrosis, so we are going to perform the transperitoneal ureterolysis. So we are going to lyse the adhesions, and after that we are going to wrap the ureter with omentum. This is known as omental wrapping. For secondary retroperitoneal fibrosis, we go for transperitoneal ureterolysis with omental wrapping. Clear? So this is how we manage the patients of retroperitoneal fibrosis.